Good morning and welcome to today's program, Current Trends in Critical Care Nutrition, which is sponsored by Fresenius Kabi. My name is Tracy Ravello. I'm the Marketing Director for Parenteral Nutrition with Fresenius Kabi, and I'll be your host today. First, I'd like to thank you all for joining us this morning during the Critical Care Congress meeting. Over the next hour, our experts will discuss advantages in nutrition therapy in the chronic and acute care settings. At the end of the presentation, we will have a Q&A session to address some of your questions that you submit. You can submit questions at any time throughout the presentation during the Q&A by clicking on the Q&A icon located at the bottom of your screen. Before we begin, I'd like to introduce you to our experts. Dr. Martin Rosenthal is an assistant professor of surgery on the acute care surgery team at the University of Florida College of Medicine. He is the director of abdominal wall reconstruction and intestinal rehab services at UF Health, as well as the chair of the University of Florida Nutrition Committee. Dr. Rosenthal earned his medical degree from Mercer University School of Medicine in Savannah, Georgia, and completed a general surgery residency and fellowship in critical care medicine at the University of Florida. His postgraduate surgical training also included a nutrition fellowship at Louisville University and Oregon Health Sciences University, as well as an abdominal wall reconstruction course at Oregon Health Sciences University. Dr. Rosenthal is board certified in surgical critical care, and he is a member of several professional and medical organizations, including the American Society of Enteral and Parenteral Nutrition, the Florida chapter of American Society of Parenteral and Enteral Nutrition, the Society of Critical Care Medicine, the Florida Committee on Trauma, and as a fellow of the American College of Surgeons. Dr. Rosenthal has authored numerous peer-reviewed journals, book chapters, and served as a reviewer for several academic journals. Dr. Rosenthal's clinical expertise in providing state-of-the-art care for patients with large abdominal wall hernias and cutaneous fistulas, traumatically injured patients, and critically ill ICU patients. He is regarded as an expert in nutrition therapies to decrease inflammation and catabolism, and continues to contribute to this medical literature in this area. Also joining us this morning is Dr. David Evans. Dr. Evans is a trauma, acute care, and critical surgeon at Ohio Health Grant Medical Center in Columbus, Ohio, and the medical director for the System of Nutrition Support Team at Ohio Health, which is a 12-hospital network. Prior to his current role, he was Director of Nutrition Support Services, Trauma Medical Director, and Assistant Professor of Surgery at The Ohio State University. His interests include nutritional support in surgical and ICU patients and research in surgery and trauma care. He has served as an investigator in multiple clinical trials in critically ill patients focused in the areas of nutrition and infection, and is the author of over 100 peer-reviewed publications. I'd like to welcome both Dr. Rosenthal and Dr. Evans this morning for our presentation. And now I'll invite Dr. Rosenthal to begin the presentation. Dr. Rosenthal.
Thank you so much, Tracy. I'm going to start off today with discussing chronic critical ill patients and what's kind of new in how we're going about treating that, and a little bit more of the evolving body of literature with this. Here are our learning objectives. We're going to discuss inflammation, all the way to PICS, what the recent evidence is showing us, some anti-inflammatory nutrients, and some anabolic or at least anti-catabolic nutrients. I have some disclosures. Here's a disclaimer. So early on, this is what we thought multiple organ failure was. You would have this surge response, and then you'd have almost a compensatory response that would bring you back to homeostasis. And if you oscillated on that curve, patients would have complications like secondary infections and stuff like that. But we now know that both SIRS and CARS are happening together. You have an innate and adaptive immunity. And when you draw this out past 14 days, you start hitting this chronic critical illness. And if that goes unchecked and you remain persistently inflamed and catabolic, immunosuppressed, you will hit the PICS phenotype. Recently, we just published this, which was an interesting retrospective review of 56 chronic critically ill patients, and I matched it to 112 rapid recovery, or the ones that would get out of the ICU before that 14-day mark. And so we double matched it just to increase the power of the analysis. We matched it for Charleston Comorbidity Index, age, sex, and Apache 2 score. And the patients that we had within this month period, they received 75% of their goal calories, which actually is not terrible. And it's pretty good based off of published standards. But these are the patients in my surgical ICU and my trauma ICU that if you think about what's going on in the first week of their ICU stay, these are the patients that are going back and forth to the operating room for source control. They're getting damage control operations if they're trauma patients. And so if I excluded the calories from the first week, we actually reached 88% of goal calories within the latter 3 weeks of the study period. So when we looked at the chronic critically ill folks and compared them to the rapid recovery, they would go to non-home discharges. And what does that mean? That usually means that they're going to an LTAC, a SNF, not necessarily a rehab, because that's actually a favorable discharge. 81% of the time, these folks are going to need some extra care after their hospital stay. They're not going home. And when you look at their 12-month survival, a third of the patients that were critically ill or chronic critically ill perished, whereas only 8% in the rapid recovery. And so then we looked at biomarkers. And so these patients that are chronically inflamed and are reaching this PICS point, you could see that the pink or the red is chronic critical ill compared to the blue, which is the rapid recovery, and they stay inflamed based off of IL-6, IL-8 biomarkers. CRP traced these biomarkers as well. They remain immunosuppressed, looking at absolute lymphocyte count and soluble programmed death ligand 1, which is PD-L1, and they still remain immunosuppressed. And then when we look at catabolism or even just stress metabolism, their glucagon-like peptide were elevated, though the urinary 3-methylhistidine was not statistically significant. There was a trend toward having higher 3-methylhistidine in the urine. And so 3-methylhistidine actually is a breakdown component. When you start breaking down lean muscle mass, you release the 3-methylhistidine in your urine, and it can be a good biomarker looking at catabolism. So what about functional scores? On the one side, you have the Zubrod disability score. So Zubrod is a score from 1 to 5, 1 being good, means you're back to baseline and functional, 5 meaning death. Anything in between is increasing disability. And if you get to 4, that means you're fully dependent on others for support and care. And so you could see that this chronic critically ill folks had an average Zubrod score out to a year at 3.5. That's incredible, because that means they're just not able to care for themselves. And you can see that the short physical battery, again, the CCI folks did worse on physical performance. What about quality? And so we use the EQ 5D, the quality questionnaire, and you can see that chronic critically ill patients did not have the quality that the rapid recovery folks reported. So why does this matter? Chronic critical ill folks is about 5 to 6% of all ICU admissions. And then in the surgical patient population, about 20% of all trauma patients that came to University of Florida will develop CCI, whereas 50% of sepsis patients. So if you have surgical sepsis, it's a coin flip whether you're going to become chronic critically ill, which I found to be a pretty staggering number. More than 380,000 cases with 107,000 in-hospital deaths. Patients that develop CCI devoured almost a third of all ICU utilizations, and you could see the inordinate cost down at the bottom. So what do we do? I just showed you that gold standard evidence-based nutrition therapies don't exactly help break the cycle of this catabolic, inflamed and immunosuppressed patients. So how do we go about feeding them? We got to change what we're doing, or we got to do something a little bit better than what we've been doing. And since the literature, about 2012, we've doubled the number of studies looking at omega-3 fatty acid parental nutrients. And here you can see that the signal shows that using omega-3 fatty acids 40% lower infectious rate. Sepsis was 56% lower. Length of stay was almost 2 days lower in both ICU and hospital. And though the statistical significance wasn't really reported, there was a trend in 16% reduction in 30-day mortality. So I do think using omega-3 fatty acids is a nice way to try and break that inflammatory cycle. Here were the reported summaries from a lipid panel. And in this discussion, we basically said that all the experts agreed that omega-3 fatty acids can be used in chronic critically ill patients and PICS patients, that there is benefit with omega-3 fatty acids. The other thing that I really am excited about, and I'm hoping that this does pan out, is that these specialized pro-resolving mediators, the SPMs, there's 3 different types: resolvins, merisins, and protectins. They all help decrease inflammatory, and they break the inflammatory cycle using our own endogenous pathways. And so we published this review looking at, well, maybe if the 2015 meta-analyses that didn't really show fish oil to have benefit but no harm, maybe these SPMs might be the actual bioactive component of fish oil and therefore serve a benefit to our patients. Next, I wanted to kind of brush on the hot topic of the microbiome and how the gut bacteria can impact our health. There's lots of stuff coming out right now, and there are strong signals in various probiotics. So what are these mechanisms and how we're going to go about doing that? This is Eli Mechnikov. He's a Ukrainian immunologist. He's actually a Nobel laureate, and he was the one who discovered the macrophages. But he postulated that a group of Bulgarian peasants who were living longer lived so because of their consumption of sour milk or fermented milk with probiotics. So he started thinking about probiotics back in 1907. And then the microbiome, what is it about ICU or critically ill folks that alters the microbiome? These are my partners and myself, and everything we do to an ICU patient will have an impact on their microbiome. Everything from giving them blood products, fluid resuscitation, even opiates. Opiates like morphine can increase quorum and telesensing. The PPIs and H2 blockers, the vasopressors, everything has an impact on these ICU patients that alters the microbiome and can increase the pathobiome, as Dr. Alverdi has reported. Here's the mechanisms of how probiotics actually help us. They competitively inhibit other bacteria from binding to our mucosa, kind of like in H. pylori. They increase the actual mucus production. They decrease adherence. They actually produce different compounds like vector-senescens, defensins, just to help bind pathogens and shed them. They preserve tight junctions, and they also stimulate good immunity. Here was a meta-analysis that Stephen Anton published. He looked at 49 articles, and he wanted to see what had the biggest impact in decreasing inflammation in folks that are a little bit older. I think it was over 65 years old. And so he looked at IL-6 and CRP, and as you can see in this corner, the thing that decreased the overall IL-6 CRP the most was probiotics. It was incredible to see this type of intervention, especially when you put it up against omega-3 fatty acids, ARBs, and vitamin D. So what about anabolic versus anti-catabolic? A lot of people think they're the same, but they are in a way, but they're not. And so when we look at specific nutrients that can help promote anabolism and decrease inflammation, we look at leucine and arginine, and then I'm going to briefly show you some of the stuff that David Herndon has been doing. So arginine is a conditional amino acid. A lot of us know that. And it's deficient during stress states. So like sepsis, polytrauma, burn, necrotizing pancreatitis. All these patients that are in my ICU have arginine deficiency. And it's required for good immune function, wound healing. And, there's this controversy over giving arginine supplementation during sepsis. But do remember, these are the chronic critically ill patients. They're outside that septic window. They just haven't gotten over the hurdle or out of the spiral. And here's how they become deficient. So there's a lot of arginase secreted in the system that breaks down arginine. And then the immunosuppression is secondary to T cell receptors. And here you can see the list, how arginine actually functions into T cell receptor. The biggest one is that it decreases T cell receptor with the loss of the zeta chain. When you have loss of the zeta chain, you no longer will have a functional T cell, and you have immunosuppression. You have energy to recall and decrease immunologic memory, which is super important when you're chronic critically ill and you're fighting to decrease nosocomial infections. You need a functional T cell. So what about leucine? Leucine stimulates the mammalian target of rapamycin, or mTOR, to increase protein synthesis for hypertrophic muscle growth, as well as inhibit proteasome and autophagy protein breakdown. Ultimately, what this does is it promotes anabolic growth and decreases catabolism. Interestingly, though, the leucine also needs arginine in order to truly stimulate that mTOR receptor. Here we see that there's two different targets. There's mTOR1, which is for cell growth. mTOR2 promotes cell proliferation and survival. And both of these need arginine, as you can see below. Lastly, I just wanted to very quickly touch on kind of anti-catabolic and anabolic medications or adjuncts that we have. Here's David Herndon's study with Mark Jesse, and what they show is that insulin, propranolol, oxandrolone, even growth hormone, all these adjuncts will decrease the catabolic nature of a big burn in the pediatric patient population. And so what it is bigger than, I think it was 35% burn in a child. You would have decrease VO2 max, you'd have increased bone mineral density, you have preservation of lean muscle mass. And so these adjuncts are things that we can add to our nutrients to hopefully break that cycle in the chronic critically ill patients. Without further ado, I'd like to also introduce Dr. Evans, and he's going to talk to us about the acute side of critical illness. And I really, really appreciate you guys listening and inviting me to this format. Thank you.
Right. Well, thank you. Thanks for kicking things off, Martin. It's a pleasure to be here speaking with everybody today. And thanks for getting up early for those of you who may have across the country. So, I'm going to be talking about um, those are my disclosures. I'll highlight them as we go. I'm going to be talking today about how can we improve our delivery of enteral feeding? How can we improve the tolerance of enteral feeding? Then move a little bit more into the realm of parenteral nutrition and some of the innovations there, some of the new strategies that we can employ in the ICU, and the importance of our lipid selection. So there's a lot of ground here to cover, and I'm going to try to move pretty quickly, but I've got a lot of content. So, of course, we all know that calorie delivery is very important. And typically, when we can get at least to 80% of our goal calories, that's when the mortality in our ICU patients is the lowest. And so that's often a goal of ours. But we know that throughout the world, and particularly in the United States, we don't do a particularly good job of this. So this is data from Darren Highland, almost hard to believe a decade ago now, showing that in the US, 91% of our patients do not achieve the adequate nutritional delivery of at least 80% of their goal calories. And even when you look around the world, while they're doing best in Asia, it's still 70% not achieving those goals. So, really, this is an international problem. And so there's been a lot of interest in looking at this. And over the last decade, really, there have been several studies looking at different technologies and drug innovations to try to improve tolerance of enteral nutrition. I just wanted to highlight a few of those really quickly. So, camisinol, this was a phase 2 trial of a motilin receptor agonist. It did not show benefit, and so that development halted. I was involved with one called ulimarelin. This was a ghrelin agonist. So this was a drug that it stimulated gastric emptying, but it also was thought to improve protein synthesis and muscle synthesis, and have some anabolic effects. It tended in the trial, it was a superiority trial, and actually the results were that it was comparable to metoclopramide, but there wasn't a strong advantage, and so the development of that was halted. There is still one drug that's on the horizon, possibly. It's It's a 5-HT4 receptor agonist. So kind of think of it in the same family as like a Zofran or something. But this this is still in development for improving postoperative gastrointestinal dysfunction. But the critical care trial, they did a small phase 2 trial that showed some efficacy, that it was comparable to Reglan. In a phase 3, they stopped after only one patient enrollment. So I think we may see this drug come up in the postoperative GI dysfunction world, and then we may have the opportunity to translate it to critical care. But otherwise, that trial is not ongoing. And then finally, there is a feeding tube technology that used electric stimulation. It was an NG or NJ tube that basically used electrical current to try to stimulate the MMCs, the myenteric plexus, to stimulate forward propulsion of the GI tract. But this did not result in an improvement in tube feed delivery, and unfortunately increased arrhythmia development. So that is also no longer in development. So what have we learned about prokinetics? So I think that we've learned that it can that metoclopramide can be dosed perhaps more safely than we often do. In that Uli-Morellin trial that I mentioned, we dosed metoclopramide at 10 milligrams Q8 using 30-minute infusions rather than the kind of traditional 2 to 5 minute push that Reglan had been dosed at when it was IV. When we did that, there was no increase in delirium or agitation with the use of Reglan. Only 2 out of 58 patients developed prolonged QTC intervals. We'd actually already excluded patients with prolonged QT prior to it, or prior to the trial. And comparable to prior studies, 13% of these patients, of course, is a very critically ill population, developed atrial fibrillation. And so with this, we've actually built our EPIC so that we can now give metoclopramide in 30-minute IV piggyback in saline or dextrose rather than pushing it. And I think that's something to consider if you're concerned about it. There have been multiple meta-analyses that do show that both Reglan and erythromycin can be effective to reduce feeding intolerance, reduce the development of high gastric residuals, actually improve the success of achieving a post-pyloric feeding tube placement. So, think about this: if you're doing your non-image guided Doboff placements or nasojejunal placements, you're having trouble getting your tube through the pylorus, that Reglan in particular has been shown to help with achieving that. And that with the use of these drugs, there's no increase in vomiting, diarrhea, length of stay, or mortality. So they are effective. And also, the two drugs can be better than one. And so this is data just showing that the combination of erythromycin and Reglan can help achieve higher success in delivering your enteral nutrition. So think about that combination as well. We've also, in the last 10 years, talked a lot about volume-based feeding. And so I'm sure most of you have encountered this in some form or fashion. But essentially, this is the idea that our tube feeds would not be set at a goal rate, that we wouldn't dial in a certain rate, but that we empower the nurses to basically control the feeding at the bedside with a set target volume goal for the day, so that let's say the tube feeds were held for a few hours because of a study or some other event with the patient, that the nurses can turn up the tube feeds and try to catch up using a rate as high as 150 milliliters an hour to try to catch up and increase feeding delivery. And we do have some data on this. So Darren Hyland published a cluster-based randomized control trial over 500 patients. They increased the proportion of patients who got goal calories by 10%, those that achieved goal protein by 13%. There was a trauma ICU that published a single center in South Carolina, almost 500 patients. They increased their delivery from 27% achieving goal calories to 57% achieving goal calories, or at least 80% of their goal calories, using a volume-based strategy without increases in emesis. And interestingly, they actually had less hyperglycemia when they were doing volume-based feeding. And then finally, there was this more recent trial published in JPEN, 189 patients with similar results in a mixed ICU setting. course, a lot of this really has been focused on the idea that we want to increase protein. And, historically, we often used to say that, well, if we're increasing protein, we probably can't utilize it, that we're going to burn it as a fuel source. But I think that we're learning that that's not the case, that we can, in fact, in the ICU, and I believe this is Scandinavian data, although I may be wrong on that, that they were. As they increased amino acid delivery, we did achieve positive protein balance. And this has been shown multiple times. But also, what's interesting about this study is that they looked at phenylalanine oxidation. So they're asking the question, are we burning protein as fuel when we deliver extra protein? And the answer was that they were not. That when we deliver extra protein, it can still be utilized for protein synthesis, for muscle building, muscle maintenance. It's not going to be burned specifically as a fuel source. Um, this graph comes from or from a subset of the Redoxis trial. So this was the 1,200 patient major ICU trial, and they looked at the delivery of protein and also the delivery of just overall adequate nutrition. And so for every 25% increase in the delivery of nutrition, was translated to about 30 grams of protein per kilo per day. For every increase by that much, at 3 months, they saw that their patients were stronger in these three SF36 subset scores. So, physical function, the role physical, and the PCS subset scores of the SF36 assessment tool. So, essentially, patients were stronger. They had not lost as much muscle mass when they were receiving more protein, more nutritional delivery while they were in the ICU. These effects were still measurable at 6 months, although at that point they weren't statistically significant. I guess I would hope that maybe there was some catch up among those patients who had poor nutrition. Now, notice that we are only looking at about 200 patients who are making the follow up at this point, despite it being a approximately 1,200 patient trial. Another idea that's been in the news a little more recently has been this idea of a protein ramp up and maybe fine tuning our deliveries. So, is it always just going to be more protein, more protein, more protein? Maybe not. So, this addresses some of the concerns about overfeeding in the early kind of phase one or day 1 through 4 phase of acute illness. And this is a trial coming out of the Netherlands where they basically did a protein ramp up approach. So, in the first 4 days, they worked to goal more slowly, building up to getting over 1 gram per kilo per day by about day 4. And then by day 6 and later on, they were targeting greater than 1.2 grams per kilo per day. Once the patients were coming out of the ICU, they were moving them up to 1.5 to 2 grams of kilo per day. And then even post hospitalization, really emphasizing that post hospital phase is crucial. Um, Getting up above 2 grams per kilo per day in the post hospitalization. So um, this protein ramp up strategy, I think, has promise, and I think we need more data on it. This is their initial data. They showed that their patients where they started low with the less than 8 grams or zero point 0.8 grams of protein per kilo per day in the first 3 days, but then moved it up after day 4. These patients had higher survival, even better survival than those who were getting higher protein delivery early on. So this is intriguing. I think we need more data around this, but definitely this protein ramp up strategy is something to be thinking about. We also know that the delivery of protein is important. The timing. We're all conditioned in our kind of typical American diet to have typically low protein intake up until dinner time and then large protein intake after that. But for our patients in the recovery phase, we really need to focus on dividing protein doses relatively evenly throughout the course of the day. This helps achieve the maximum rate of protein synthesis, getting in those equal divided doses. And I think, in our post ICU patients, that needs to be part of the story. Of course, exercise is part of the story as well. And this is just some British data showing that the increase in, or actually, I believe it's American data in Lancet, but increased physical exercise in the ICU improves outcomes. And I think, we could do a whole lecture just on how you combine exercise with protein delivery to try to optimize your outcomes. And Dr. Rosenthal mentioned some of the anabolic agents, which are a particular interest of mine as well. But Essentially, when patients exercised in the ICU, they almost doubled their ability to go home after discharge rather than requiring rehabilitation, and the death rates tended to be lower as well. So let's shift gears a bit. This is we're going to be talking about malabsorption and how can we reduce and improve our tube feed diarrhea. This is, of course, a big concern of our staff in the ICU, and frequently a reason that I see the tube feeds inappropriately turned off. And there's a lot going on, of course, in our patients. So particularly early on, we may see postoperative ileus. We may have electrolyte deficiencies. We're on vasopressors. We're really on this tightrope. We also, I think, underappreciate the neurogenic disorders that may exist in our patients, either from their um, chronic state, their acute illness, or um, or their post-surgical condition. So there may be pelvic floor disorders, there may be neurodevelopment issues, or enteric nervous system issues, spinal cord injury, and so certainly we need to be aware of appropriate bowel regimens, bowel health, addressing immobility. Those kinds of things. Then on the other end of the spectrum, of course, we have diarrhea, and this could be, because we were over treating ileus, or not over treating, but after the ileus and constipation resolved, now we're dealing with stool softeners, laxatives that may be causing problems. We may have gut dysbiosis from overuse of antibiotics. We may have enteritis in our patients, whether it's C. diff, infectious, ischemic, etc. So there's a lot there. So I would encourage you to think about having an algorithm to reduce diarrhea or to address diarrhea in your ICU. And this is something I've developed, just systematizing thoughts that I think many of us already have. But the idea that, first check to make sure whether there's an iatrogenic cause, stool softeners, laxatives, promotility agents that we now need to stop now that the bowel function's returned. Is there an infectious etiology? Do we need to check the C. diff? Do we need to send other stool studies? Should we change to a semi-elemental or elemental feed to try to improve tolerance? Should we consider adding fiber if we don't already have a fiber-containing tube feed going? Should we add extra fiber? Um, I often will add extra guar gum. That's an easy one to do if you don't have fiber already in your tube feeding. And then finally, is this an antibiotic associated diarrhea? Is there an opportunity either for probiotics, as Rosenthal mentioned, or should we be stopping antibiotics? So there's a lot there, but there's also a new emerging area that I'm very interested in, and I should disclose that I have worked with the company that I'm going to be mentioning in a minute, but exocrine pancreatic insufficiency in the ICU. Certainly there are patients that we've always known and always recognized had this. So EPI, as we'll call it for short, such as the cystic fibrosis population. Also chronic pancreatitis patients, where after 10 years of chronic pancreatitis, 50% of these patients may have EPI, up to 80% by 25 years after diagnosis. Pancreatic surgery, this one's probably often underappreciated, but up to 74% of patients after cancer surgery of the pancreas have exocrine pancreatic insufficiency. And even those who don't have surgery, their duct may be obstructed, their gland is not functioning well, and they have high EPI rates that also progress as their disease progresses. Also, though, even acute pancreatitis, up to 33% of the severe cases of acute pancreatitis may have some EPI. And I can't tell you how many times, I've had an acute pancreatitis patient where they've had tube feed diarrhea, and I just, it's been frustrating. But I think this is part of the story, and we know also from this data coming from China in 2013, they looked at 563 patients in their ICU. They actually excluded everyone from the slide that I just showed you, so anyone that had a known pancreatic disease was excluded, and they went around measuring fecal elastase levels, and they saw low fecal elastase levels in 52% of their patients. 18% of them had severely low levels. And so this is an indicator that these patients, there may actually be a lot more exocrine pancreatic insufficiency in the ICU than we've ever recognized. And I think that this is in part because there really aren't a lot of ways to monitor the function of the pancreas. And so I would challenge you to think about this as you're moving forward in your practice, that perhaps we have more of this than we realized. And in this Chinese study, they saw that EPI typically was associated with patients with shock or sepsis, diabetes, post-cardiac arrest, elevated lactates, or on the vent or on CRRT. So, um, there's a lot there, but certainly the pancreas is an organ that we're otherwise not particularly well situated to assess. And even though we can look at the endocrine function through blood glucose management, that does not strongly correlate with the exocrine function. Of course, we can deliver lipase and we can crush oral enzymes and deliver them through feeding tubes, but that achieves a bolus effect and it's not particularly optimal for our continuous feeds. And so, the product that I've been affiliated with and working with in the last few years is this immobilized lipase coated Microsphere cartridge, where basically it's a cartridge that connects to your feeding tube circuit and those little micro beads that are in it are coated with immobilized lipase. Tube feeds bathe the lipase, and the lipase hydrolyzes the triglycerides into monoglycerides and free fatty acids and improves the tolerance. And so this has already been proven, is already FDA approved. It's already on the market with data showing that it's very efficacious in the cystic fibrosis population and eliminates a lot of the GI intolerance that that population has. But also, there are ongoing trials in short bowel, post pancreatectomy, in the surgical ICU for feeding intolerance, and the PICU as well, and severe pancreatitis. And you can see where all these trials are going on around the country. So I think we're going to be learning a lot more about this, and this is going to be an area ripe for discussion in the future. I also, no talk on an update in critical care nutrition could be complete without mentioning that our enteral feeding connectors are changing. And this may be something that you're already very aware of, or it may be something that's brand new. But um, in the course of this year, we're going to see the feeding tubes as we have known them for years, to really probably completely phase out if things go as scheduled in the United States. We're moving to this device called the InFit device. It's a keyed, basically reverse lure lock connection that prevents misconnections or incompatibility, so you can't connect integral to parenteral or vice versa. It's actually legally required in California, even though I understand it's still not fully implemented even there. You probably already have this on your feeding set. If you twist off the end of your feeding set connector, you'll probably find an InFit connector underneath there, because right now we're using these transition connectors. But if this is new to you, if this is something that you haven't encountered, and I can tell you that in Ohio, when I'm talking to providers outside of kind of the nutrition expert community, um, most of the surgeons, for example, are not aware of this coming technology and transition. But this is going to require a lot of things because, for example, you're going to need new syringes to be able to connect to feeding tubes, to push meds, push flushes, things like that. So there's going to be a big lift if this is something you need to be planning. Now, in North America, we have about 30% implementation so far. In Europe is already hit approximately 100%. And by the 1st of July, they're saying that the legacy, the old feeding tubes are no longer going to be available for purchase. And by the 1st of next year, we're going to be phasing out those transition sets and connectors that I showed you. So, excuse me. So shifting gears again. So the rest of the talk, I want to show you a lot of the newer evidence about the role of parenteral versus enteral nutrition. And really, I think, it may be as simple as this question of not deciding, are we stuck? Are we going to be doing starvation, or are we doing the hospital food, or are we going to be doing enteral, or are we going to be doing parenteral? And we all know that we have many patients where enteral, for whatever reason, despite all the stuff that I just showed you, trying to improve tolerance isn't possible. And so, let's go back to primary sources. So Aspen, SCCM guidelines, 2016. What do they recommend? We recommend that in patients at low or high risk, parenteral nutrition be considered after 7 to 10 days if unable to meet 60% of energy and protein requirements. And they have this statement that I love. In the patient determined to be at high nutrition risk with an elevated NRS 2002 or Nutrix score, or they're severely malnourished, When enteral isn't feasible, we suggest initiating exclusive parenteral nutrition as soon as possible following ICU admission. So, Nutrix score, I think it's a very valuable score. I think it's good for research purposes. We implemented this, we tried it out. Our dietitians, it first took about 30 minutes for them to do an Apache and a SOFA. As they got really good at it, they could do this within about 15 minutes. But we did learn that it wasn't particularly practical for daily use, but I do love it. I do want to share it with you. I'm hoping that someday we can get electronic calculations of Apache, and we already actually have electronic SOFA scores in my hospital's Epic system. If we could get electronic Apache scores, I think that would be the clincher to making Nutric a reality. But those patients with a high score, 5 to 9 points, um, that was associated with worse clinical outcomes, and we think those are the patients who benefit from aggressive nutrition. Not just do we think that, I'm going to show you that. So this is data essentially showing that if you have a high Nutrix score, you are much more nutritionally sensitive because you're at nutrition risk. So we see that as if you're in that high group, you have quite a slope to this line. If you go from 0% nutrition delivery, mortality is around 55% or so. If you can ramp that up to 100% nutrition delivery, mortality comes down to about 25% versus those patients in the low Nutri group. So remember, that's typically low Apache, low SOFA, not elderly, no pre existing malnutrition before coming to the hospital. Those patients are not as nutritionally sensitive. And whether they receive low delivery or high delivery of enteral nutrition, their outcomes are relatively similar. You still see there's a slight slope to that, but not as strong. You can actually replicate this for other things. In addition to Nutrix score, BMI can play a role. So those patients with a BMI less than 20 are extremely sensitive. Those patients with BMIs of greater than 40 or 35 to 40, those also have quite a slope. So the same idea, the same phenomenon that they are relatively sensitive to nutritional delivery and that their outcome, their survival will be enhanced if they can get to their goal versus those in kind of that 25 to 35 BMI range. Um, they're not as nutritionally sensitive. I'm not saying don't feed, but perhaps they don't have that same risk when they're not getting adequate delivery. And then I'd be remiss when we're talking about recognizing which patients are at risk that we can't use albumin and pre-albumin to diagnose malnutrition in the ICU. This is our Aspen Malnutrition Committee consensus statement that came out end of last year that essentially albumin and prealbumin in the ICU or anywhere, in fact, represent a decline in the presence of inflammation, that they're negative acute phase reactants associated with nutrition risk, and they may have a role for that, but they aren't reflective of malnutrition, and that they may normalize as inflammation is going away, as our but that also may mean that our nutrition risk is reducing. So I'm not saying that they're totally worthless, but that they don't measure total body protein, they don't measure total body muscle mass, and they should not be used as nutrition markers per se. So, once again, back to the big question. Can't decide. Is it parenteral? I made this one. The last one was somebody else, but is it parenteral or is it enteral? Well, so Aspen has some nice, slightly more newer guidelines that I think are worth visiting. So in 2018, um, they're telling us that in cases of contraindication to oral or enteral, parenteral should be implemented within 3 to 7 days. Note that they're moving that time up from 7 to 10 to 3. Um, Early and progressive parenteral nutrition, instead of no nutrition, should be used in cases where there's no contraindication or when there's a contraindication for enteral nutrition in severely malnourished patients. So strong statement if the patient's severely malnourished. Um, they do address the question of supplemental parenteral nutrition, and they really tell us that we should weigh that on a case by case basis. I'll be showing you some data on that here in the final parts of the talk. Um, and that parenteral nutrition, of course, though, should still not be preferred in terms of, we should maximize attempts to achieve enteral tolerance first. So let's go back to the future for a second. So where did this 7 to 10 days of NPO before TPN come from? So, in the 80s and even, early 1990s, there was a bit of a difference in how parenteral nutrition was done. So typically patients were getting 40 to 45 kcals per kilo. They were often targeting a goal to achieve hyperalimentation with a target of 1,000 kcals over the resting energy expenditure per day. Blood glucose control was different. Glucoses in the 300s before aggressive treatment were more common. Of course, the indications weren't as well defined. We didn't have beautiful Aspen SCCM guidelines by, folks like McClave, Beth Taylor to look at. So, I love these guidelines. Um, we individualize, parenteral nutrition was more individualized, less standardized. Our compounding was not as centralized. Most hospitals were doing their own. I'd say that that's the minority of hospitals now doing their own compounding. And if they are, they're high volume centers. Um, and there were fewer safety mechanisms in place. And really the idea was that this was total parenteral nutrition. So TPN. I think the study that really kind of deep sexed TPN, for at least in the short term, was this 1991 VA collaborative trial. And what they did is they looked at patients who needed a laparotomy or thoracotomy, but who could wait. They screened them for malnutrition. And if they had any signs of malnutrition, they treated them for 7 to 10 days with TPN before surgery, achieving 1,000 kcals over their resting energy expenditure. So doing hyperalimentation. And this is where we kind of learned TPN is bad if you grew up thinking that. And I don't, of course. Um, but the key thing was that the TPN patients had over twice as many infections, major infections, 14% in the TPN group versus 6% in the control group. And look at how many catheter-associated complications they had. Of course, they were putting in old school central lines and getting the pneumothoraces and the hematomas and other things like that to show for it. And so, but what's interesting is that if you really dug into this paper, even back then, the patients with severe malnutrition actually still did benefit significantly from TPN. They actually had fewer infectious complications, 15 versus 21%. And most impressively, they reduced their non-infectious complications of surgery from 42% down to 5%. So, this really did show that the severely malnourished patients did benefit. So then we have to ask our questions. They were using the subjective global assessment, I think, typically in that trial. But, how do we diagnose malnutrition today? And, um, you know, our dietitians have embraced this and loved it, but I think that as a surgeon, for example, there's still a lot to be said for getting this out in the public. So, not just is malnutrition poor energy intake defined as reduced oral intake for a certain period of time, and not just is it weight loss, but it's also the loss of subcutaneous fat. It's the loss of muscle mass. We're teaching nutrition focused physical examinations, looking for subtle signs, like temporal muscle wasting, for example. Um, it can be edema, fluid accumulation, and I really hang my hat a lot on the fact that it is diminished functional status. So in the ICU, this may be hand grip strength. There is data published in Surgery last year showing that time stair climbs preoperatively are a stronger predictive thing than anything we have, including the NISQIP calculator for identifying those patients that are at high risk. So if you can go up and down a flight of stairs fairly quickly, you're going to do great when you have surgery versus those who can't. Now, we're very interested in the idea of using imaging technology. And of course, as a trauma surgeon, all of my patients have been imaged. These are 3 patients that came to me over the course of about a week, quite a few years ago. But on the left, we've got a patient with a BMI of 25, a healthy CrossFit athlete. In the middle, we have a patient with a CD4 count of 50, with a bowel obstruction and severe AIDS, not just HIV, but AIDS. And then on the right, we have a woman with sarcopenic obesity, a BMI of 58. A lot of people might have looked at her and said, hey, she's well nourished, she's overweight, she's obese. But no, in reality, look, there's fatty infiltrate along all these the spine paraspinous muscles. There's fat all throughout them. There's very little rectus musculature, very little obliques. Now, I don't know if you can see my pointer. The AIDS patient here, he has slit-like psoas muscles versus these big, well-developed, round tenderloin muscles in our healthy CrossFit athlete who I think had appendicitis. And so size may be important. I'm very interested in looking at the quality of the muscle. What is the density of the muscle? Is there fatty infiltration in the muscle? Is there fluid? Is there edema in the muscle? And we can get some assessment of this using the Hounsfield units, using our bedside PACS viewer systems to look at X-rays. We can circle out the muscles, calculate what the psoas mean density is in there. And we know that in our trauma patients, for example, that those patients with a psoas Hounsfield density below 40 had much higher mortality, longer length of stay, more complications, and risk of needing to be discharged to a SNF or something like that. So, malnutrition, we have a new definition. We have new ideas. Maybe I've raised more confusion than given you answers, but there are a lot of different things that we can think about, like muscle mass, as we refine. What else has changed since the 90s? We have better glycemic control. We've shifted away from hyperalimentation using more realistic 20 to 30 kcal per kilo goals. Our CVC care is much safer. And the Aspen group published in 2004 these safe practices for parenteral nutrition. I'll just highlight them. We standardized our order entry, our order forms. We improved the quality of compounding. We've taken care to reduce precipitation reactions in TPN. We've dedicated a lumen for the infusion to reduce CLABSIs. We are minimizing the addition of additional medications to parenteral nutrition, minimizing our Y site infusions, being very vigilant to reduce CLABSI. And that's the compounder photograph there where all this gets mixed together. And I think that through these strategies as well, we've really improved the safety. And so now moving into the modern era, I want to show you new data, new evidence about parenteral nutrition, starting with the Harvey Trial, published New England Journal 2014. That 33 English ICUs randomized patients 1-to-1 enteral to parenteral, delivering 25 kcals per kilo in both groups. They don't tell us which type of lipid. I tried to reach out to them. I still haven't ever gotten a clear answer on this. But they enrolled the patients very early on. They treated them in one of the two arms for 5 days, and they saw equivalency essentially of outcome. So whether you receive PN or EN for the first 5 days, death rates were similar. Parenteral patients actually had less hypoglycemia. Um, and then, interestingly, there was even a signal that by the time of ICU discharge, that the parenteral patients with the early PN actually had a slightly higher survival, not statistically significant, but 26.6 versus 29.4%. So this is intriguing that perhaps parenteral nutrition in the ICU can be safe and effective. Um, Certainly, I'm not saying in place of enteral, but certainly at least when enteral can't be taken. They also showed us that these patients had very few severe adverse events. The PN and the EN groups were pretty equivalent. It was a fairly sick population. 80% of the patients were receiving vasopressors on average. Then the Australia New Zealand group responded, a very similar type of publication, 1-to-1 randomization, early parenteral versus standard nutrition. So what this was a goal to achieve enteral. Enteral typically wasn't being started in the first 2 days or so, but being ramped up after that. They were enrolling patients who wouldn't be fed immediately, but were being anticipated to be fed within the first 5 days. Sorry, there's a typo there. The patients were getting 3-in-1 bags with interlipid. So still old school lipids. We'll get to that in a moment. And they treated them for 5 days, and similar results. They saw similar safety, similar survival, and then very intriguingly, the patients who got the early parenteral nutrition actually had a slightly statistically significant, measurably better general health status on their quality of life follow-up scores. And then they also, interestingly, did not have an increased risk of infection. So this brings us to the question: if early parenteral nutrition is safe and effective, what about early and supplemental? So the Europeans have been very interested in this idea. It hasn't been in use in the United States a lot, but they've been in support of the early parenteral when EN is impossible. And so, what about the idea of supplemental? We'll move to that in a second. But also, is is PN now equal to EN? It's certainly a question that's raised by this. And then what's the impact of our new lipids? And we'll get to that. So two more trials I want to show you. Nutritria 2, this is a French study looking at patients that are mostly on vasopressors and the impact of feeding on gut ischemia, and fairly respectable doses of levofed in both populations. Um, and what they found, sorry, busy slide, but I've highlighted here at the top, mortality. So equivalent mortality, whether you were getting intraoral or parenteral nutrition, both essentially in the ICU and at 90 days. But what's interesting is that the gastrointestinal side effects, I guess it's common sense, but those patients who had parenteral nutrition had fewer GI side effects, less vomiting, less diarrhea, uh, less bowel ischemia, and fewer instances of Ogilvie syndrome or colonic pseudo-obstruction. So this got some attention because of the increased bowel ischemia with early enteral feeding. Not something we've seen in a lot of studies. And so, surviving sepsis guideline, we're not afraid of enteral feeding. We know that enteral feeding has benefits for sepsis, septic shock, helps maintain gut integrity and maintain that permeability, dampens the immune response, and modulates the metabolic response. So we're not afraid of feeding, but we do need to be thoughtful that we do have other options. So Aspen SCCM guidelines circling back that EN may be provided with caution in patients on stable chronic low vasopressor doses. Um, it should be withheld in those patients who are hypotensive with a blood pressure less than 50. Um, it should be withheld, integral should be withheld if we're starting the pressure agent or if we're escalating the pressure agent. But I feel very comfortable starting feeds once we're on stable dosing. And we need to keep in mind that there's this counter current mechanism that oxygen delivery out to the tip is vital. And if our lactates are elevated, I say don't feed. Um, I'm going to move quickly because I'm running out of time. I'm going to slip through ePanic. This is the one trial that suggested parenteral might not be as good, but there were problems with this. They were using a pure 20% dextrose infusion for the first 48 hours. 90% of these patients were surgical, 60% cardiac. These were on average, they only got 1 to 2 days of the high dextrose infusion. They weren't getting real TPN in most cases. And so that's of limited utility. I'm also going to skip through the top up trial, except just to show that we used supplemental parenteral nutrition to improve our calorie and protein delivery with equivalent survival, actually, some hint that maybe mortality was slightly improved. Um, our bloodstream infections were significantly higher when we were doing supplemental TPN. Very intriguing was this idea that performance status was improved, but we weren't able to hit statistically significance on that. But even out to 6 months, our patients may be doing slightly better when they got supplemental PN early on. And those patients, most of the signal appears to lay with those patients with the Nutrix score of 5 or more. So um, there's a similar study that was published in Denmark in 2017, the EAT-ICU study, also showing that early aggressive enteral and parenteral feeding did not appear to really improve outcomes, but it also did not increase any complications. Um, and they did not show those 6-month benefits that we found in the American, well, actually multinational top-up trial. So finally, in the last part of this, I really want to hit on lipids. And I think that the audience today is pretty sophisticated, but certainly we know that omega-3s have a wide variety, particularly the EPA and DHA from fish oil, have a wide variety of health benefits. And whether we believe that a high fish oil diet, such as an Inuit diet, or a balanced lipid diet, such as the Mediterranean diet, is superior. I think we can all agree that that's probably superior to the soybeans that we previously were using for all of our omega-6 based lipids. And so prior to 2016, in the United States, we only had soy-based lipid. And this was, it did have a little plant-based omega-3, but that's not DHA or EPA. And that's all we had. But when we look at things, we know that omega-3 is very anti-inflammatory and omega-6 is pro-inflammatory. And, Rosenthal mentioned a few of the benefits of omega-3, so I'm not going to rehash that. But it's exciting time now because we have multiple lipid options. So we have an olive oil derived lipid in the United States, 80% olive, 20% soy. So it doesn't have DHA or EPA, but certainly may have a benefit that it reduces that omega-6 intake. And there may be some anti-inflammatory benefits, although more marginal, with omega-9s that come from olive oil. There hasn't been clinical evidence of superiority on this product that I'm aware of. We also have 100% pure fish oil. This this is mostly from the pediatric population. It was used in compassionate use. Adult patients, I foresee the main use of this being as a rescue therapy when there's a lot of liver failure. And this is the interesting data from this coming from Boston Children's, published a decade ago now, showing that essentially with the use of parenteral fish oil, TPN, they could completely reduce liver failure or reverse liver failure. Billy Rubens would correct. They reduced the number of patients who required liver transplant. And so this is certainly a modern kind of miracle. So finally, I think, in our search for the perfect lipid, though, I think that a mixed oil, 4 oils, mixing things together. Of course, this is for Fresenius Kabi, sponsors of today's event. Mixing 30% soybean oil, 30% MCT, which is palm or coconut, 25% olive, 15% fish. This probably delivers our optimal omega-6 to omega-3 ratio of 2.5 to 1. These patients show improvement in LFTs. When we look at our infection rates, they're lower with the use of parenteral fish oils. When we look at our society guidelines, Aspen and Espen suggests that we would use these alternative low soy strategies, implementing perhaps fish when it's available. Canadians kind of take a different tact on it. They say the same thing, but really focus on reducing the omega-6. They don't necessarily prefer fish um, olive, but um, and the Europeans really say that in general, a blend with the omega-3s is going to be the best. That's from their guideline. We have a lot of this is just overviews, whether it's hospital length of stay, ICU length of stay, infection, mechanical ventilation, or mortality. You can find some evidence for some combination of this that we're going to get a benefit by moving away from our soy oil old school intralipid. Now, this is European 4-week outpatient data showing just a reduction in adverse events, improvement in LFTs, improvement in bilirubin with the use of the EPA and DHA fish oil containing product. Or that was SMOF specifically, the 4 oil mixture. So we know it's safe and well tolerated. Um, it has improved immune and inflammatory function and lower triglyceride levels as well. So I want to show you in our ICUs, we implemented this as well with similar results. Trends of improvement in all of our LFTs. We didn't get to statistical significance on that. I'm sure we would if we'd had more patients. Our CRPs, though, our C-reactive proteins, were cut in half statistically significantly. Our prealbumins went up. So I think we're seeing improvement in inflammation. So we're now using SMOF 4-oil lipid emulsion in all of our ICU patients. We also consider it in all of our patients who are on long-term PN therapy, those with elevations in their LFTs. And interestingly, we can also use this to increase the dose of lipid because it is safer. We can increase our dose of lipid from 1 gram per kilo per day up to 1.5 or more grams per kilo per day. And by that, we can reduce the dextrose content of our parenteral nutrition. And this may be an option if you're dealing with refractory hyperglycemia. Certainly, we do need to be aware of the allergy concern. And so I want to conclude with these 2 statements. The International Lipid Consensus Congress. Basically, one thing is we can now do early lipid containing parenteral nutrition in the ICU, and lipids are an integral part of this. I'm no longer holding lipids for the first week of the hospitalization, like the older guidelines were really pointing us to doing. I think with lipid emulsions, we can do this safely and early. We know that there's sufficient evidence in the critically ill. Dr. Rosenthal highlighted some of the mechanistic reasons that our critically ill, particularly surgical and even non-surgical patients, may benefit from this. And there was generally a fair amount of agreement on all these points. The dosing, we can bring up our lipid doses higher than we once were, up to 1.5 grams per kilo per day. We can also, we have a recommended dose there. So with that, I want to thank you. I apologize, I'm a little over time, but I'm interested to hear what the questions are. So thanks.
Thank you, Dr. Evans and Dr. Rosenthal. We do have a couple of questions in the Q&A box. So let me go with the first question. I think Dr. Rosenthal, it might be for you. Actually, Dave, you could probably take it too. SPMs seem to have promise. How do you see these delivered to patients in the future within fish oil only? And in which case, at some point, will you see an optimal dose for SPMs?
Oh, that's a really interesting question. So right now, I am unaware of any real good commercially available SPMs in the States. Now, Europe does have some products. I don't know how widely used they are, and I don't know which SPMs are in them. I trialed one of the European products and had a bunch of hydroxy lipid byproducts in them. But I don't know that we're going to find an optimal dose just yet. I do know that the SPMs have really good bioactive availability at nano and picomolars. So tiny concentrations have a pretty large impact. And so I do think that it's going to be a nice product to have, especially for our critically ill folks. And, are we going to be able to get intravenous SPMs? Sure. When we give them orally, are they going to be absorbed in critical illness? I don't know yet. And so we need to stay tuned. And I do think further research and investigation into this developing product is going to be needed.
Thanks, Dr. Rosenthal. We did have one more question about SPMs. Is there a connection between SPMs and omega-3 fatty acids?
Yes. So SPMs come from omega-3 fatty acids, fish oil, and so the DHA, EPA break down into the D and E isomers for resolvins, and they have increased concentrations if you actually take omega-3 fatty acids with an aspirin. So that aspirin is actually pretty interesting because it cleaves the omega-3 fatty acid at the enzymatic kind of breakdown to get resolvins. So if you have patients and they're okay to get an aspirin, that might not be a bad idea.
Anything to add, Dr. Evans?
No, that's interesting.
I know. All right, I'm going to move to a second question that we have. When should bedside clinicians start to worry about the gut microbiome? Commercially grade probiotics be added to their ICU nutrition regime versus waiting to start a probiotic post-ICU? And for those with a planned surgery, should they start pre-op or post-op?
Yeah, well, I think early is better. I think probiotics are often a prophylactic or prevention measure rather than a treatment. I think it's harder to get the gut microbiome to change quickly. So when should you worry about it? I think always. I think that we still need stronger data before we can maybe. Well, I don't know if we really do or not. I mean, there are a lot of studies showing reduction in VAP rates and reduction in C. diff rates. I guess I don't know why. I hear a lot of people say we do need more data, but I think we have a lot of data on probiotics, particularly in the ICU. I think a lot of the problem is that people aren't always happy with the products that are available. I think there's a lot of confusion around the different strains of, whether it's lactobacillus or Saccharomyces that we're going to use. In the surgical population, interestingly, there's even data from liver transplant, for example. So where you have immunosuppressed patients, that there is a benefit to preoperative and postoperative probiotics. And so, I think earlier is better. I think there are a variety of reasons that they haven't really caught on around the country in the ICU. But I think it's time to really, re-tackle the issue. You're muted, Tracy.
Thank you. I have one more question. So you mentioned, Dr. Evans, that the Aspen SCCM guidelines had previously said to hold soy lipids for the first week in the ICU. Do you see these guidelines changing now that we have all these new lipids available?
Oh, absolutely. I mean, I would hope that when the next guideline comes out, um, that already was one of the weaker. There was less consensus around that recommendation. I think about 2/3 of the group had recommended holding lipids for the first 7 days. We don't have a lot of clinical evidence around that. There are one or two small trials that have shown perhaps a slightly worse outcomes if they got soy-based lipids in the first week. There were similarly one or two trials that showed no difference. So I think it was out of an abundance of caution that they were doing that. Also, we do have this evidence suggesting that in the first week, we may not need to achieve that full calorie delivery. So people I think, were comfortable with holding lipids in the first week. But now if you're shifting to the idea that this isn't just nutrition, this isn't just fat delivery, but that there's a therapeutic anti-inflammatory benefit to omega-3, I think that bringing lipids in the first week becomes really paramount. And I would anticipate that recommendation is going to change. They already, those guidelines were published before any of the new lipid products were on the market. And so they were fairly cautious because we didn't know, if and when we would have those products. But I would anticipate that we're going to see that change in the update.
Any final comments from either of you today, this morning?
No, thanks for having me.
Yeah, thanks for having us. Pleasure to be here.
Well, thank you both. I think it was an insightful and presentation with lots of great perspectives. So I'd like to thank you both and thank the audience for their participation and engagement, and hope that you found today's presentation impactful. So that concludes today's program. Thank you so much, and enjoy the rest of your day.